Hello everyone, today we're going to talk about management of skin abscess in the era of methicillin-resistant Staphylococcus aureus. My profile. My name is Ana Julia Meses Mendoza. I am a student of the University Catholic of Santiago de Guayaquil. These are my account of social media, Facebook, Twitter, Facebook, and YouTube. First, definition. At present, it is observed that a high percentage referent to methicillin-resistant Staphylococcus aureus, MRSA as in the very known. The isolation of such bacteria occurs in both inpatient and outpatient, even without a pathologic history, and is associated with soft tissue infection, such as furunculi, which can progress to severe forms with significant tissue damage.
All my videos and this video is for educational purposes only. Please consult your doctor before you make any decision about your medical care.
Application in medicine. MRSA is a staphylococcus that possesses the MEK gene responsible for methicillin-resistant, since it encodes a penicillin binding protein, PBP2A, with low affinity for beta-lactam antibiotic, and they are associated with beta-lactamase inhibitors. Genomic studies have determined that MRSA strains have pathogenicity determinants, such as Staphylococcus casset, Crozon MEC, SCC MEC, and pathogen-valentin leukocidin, PVL, which is a necrotizing toxin responsible for the injury. Community association MRSA affecting skin and soft tissues, while hospital-associated MRSA causes bacteremia sepsis in surgical wounds and burns, and ventilator-related pneumonias with high morbidity and mortality. Pros and cons. Pros. In serious cases can require admission, he recommends the use of cephalosporins with sulforaphane intravenous in addition to surgical drainage, which is the most important, as well as to take sample for microbiological culture and antibiotics. Good sensitivity for chloramphenicol that are showing the strain isolated, presumably due to the relative rest in their use that has had this drug. Recent data suggest that abscesses can be successfully treated by incision and drainage alone. The antibiotic option is more crucial for the management of cellulitis, with most conform to the susceptibility profile of the circulation strain. The vast majority of lesions, 96%, resolve or improve with 7 days. Cons. It has become a major cause of skin and soft tissue infection worldwide and in our environment. It includes patients of different age and sex with variety degrees of involvement. Issue applied in Ecuador. Laboratory diagnostics of MRSA range from advanced genomic methods to conventional identification techniques, the latter after the advantage of being within the reach of any hospital microbiology laboratory. Among them is the performance of the antibiogram according to the diffusion method, using antibiotics that might resist to the penicillin, preferably cenfoxetine 30 UG, and to a lesser extent oxaline less 1 UG. The following are currently recommended as antibiotic therapy for MRSA in community-associated infection: sulfamethoxylose, trimethoprim, sulfaprime, doxycycline, or other tetracycline, or clindamycin. In severe nosocomial sepsis with poor response to the above drug, vancomycin should be used.
I'm Dr. Amy Meditz. I'm an infectious disease specialist at the Beacon Center for Infectious Disease at Boulder Community Health. Today we're going to talk about a bacteria called Methicillin-Resistant Staphylococcus aureus. This is commonly referred to as MRSA. MRSA can cause infections in different parts of the body, including the skin. MRSA infections can range from being very limited to very serious. What makes MRSA different from other forms of staph is that it cannot be killed by a number of commonly used antibiotics. This has led to this organism being called a superbug in the media. It's important to know that there are treatments for MRSA, and we commonly take care of this infection at the Beacon Center.
Hello, my name is Dr. Todd Turner. I'm going to explain an important concept called MRSA colonization. MRSA is a very common bacteria. In the majority of cases, MRSA does no harm to the colonized person. However, a person colonized with MRSA can spread the bacteria to other people through direct contact or by leaving the bacteria on commonly shared surfaces. Sometimes, a person colonized with MRSA will develop an infection. While there is not always a clear-cut reason as to why this happens, people who have recently been hospitalized, who have an underlying illness, or who have been recently taking antibiotics are more prone to infection. Good personal hygiene can reduce your risk of infection. Maintain good hand and body hygiene. Wash your hands regularly with soap and water. Avoid sharing personal items such as disposable razors, linens, and towels. Keep kitchen and bathroom surfaces clean. If you think you may have an infection, don't delay treatment. It is also very important that you complete all the antibiotics that your doctor prescribed to you for your infection.
Hello, my name is Dr. Mark King. I want to talk to you about common conditions caused by MRSA or MRSA. MRSA commonly causes skin infections such as folliculitis, cellulitis, or soft tissue abscess. Folliculitis is an infection of the hair follicles leading to skin irritation, and cellulitis is an infection of the skin and underlying tissues as shown in these images. MRSA infection can also lead to the formation of an abscess or collection of pus that builds up within the affected tissue. At times, MRSA can cause serious infections such as skin or wound infections, pneumonia, or infections of the blood. Once MRSA invades the bloodstream, other structures within the body such as joints, the spine, or the heart can become infected. On very rare occasions, skin and soft tissues can become very severe and progress rapidly, requiring surgery or a stay in the hospital.
Hi, I'm Dr. Rao. I'm here to talk to you about treatment options for MRSA infections. Treatment can take place in a variety of healthcare settings. Abscesses caused by MRSA can be drained by a surgeon or in the emergency room or urgent care center. Some small abscesses can be completely treated by drainage alone. Most of the time, antibiotics are also needed. While MRSA is resistant to several common antibiotics, there are several options that retain the ability to treat it. The length of treatment depends on the type and extent of your infection. Occasionally, if the extent of infection is too great or an individual has specific allergies or intolerances, intravenous antibiotics may be necessary. It is not uncommon for a person to experience a recurrence. If your infection returns, we may try various topical modalities to try to reduce the amount of MRSA on your skin or mucous membranes.
Thank you for watching our video on MRSA. We hope you have a better understanding of colonization, disease, and treatment of MRSA. At Beacon Center, we are happy to address any issues with MRSA. Call us at 303-415-8850 to make an appointment with one of our providers.
Professor Dave again, let's talk about staph infections.
He knows a lot about the science stuff. Professor Dave explains.
You've probably heard some talk about superbugs in the media, but what's really going on? First, let's talk about Staphylococcus aureus, which is commonly known as staph. These bacteria are typically harmless and commonly found on the skin of many healthy people. However, in certain cases, as we discussed earlier when we talked about opportunistic pathogens, these bacteria can cause serious or even deadly infections. Let's get some more information on these little critters. In the past few decades in particular, a more dangerous form of staph has emerged, which is called Methicillin-Resistant Staphylococcus aureus, or MRSA. MRSA is resistant to the entire class of beta-lactam antibiotics, which includes methicillin, penicillin, amoxicillin, and oxacillin, all antibiotics you've likely heard of and almost certainly taken in your lifetime. The different types of MRSA infections are split into categories based on where they're acquired. For instance, healthcare-acquired MRSA, or HAMRSA, has been documented since the 1960s, particularly in hospitals and other healthcare facilities. Patients with weakened immune systems, recent surgery, or those with medical devices implanted are at higher risk for HAMRSA, and the incidence of these infections has been increasing steadily over time. A second and more alarming type of MRSA infection emerged in the 1990s, called community-acquired MRSA, or CAMRSA. The points of origin for these infections can be more difficult to identify, but are thought to be common in childcare settings, long-term care facilities, athletic settings, or in individuals sharing towels or other objects. These infections often first appear as simple skin infections, but can progress into life-threatening illness. So how do these strains develop, and why do they develop? Zooming into the microscopic level, Staphylococcus aureus is the most virulent and best-known member of the group of gram-positive cocci, Staphylococcus. These bacteria have a capsule that protects their outermost layer, and they produce a slime layer that helps them bind to things like catheters, prosthetic valves, or joints, or grafts. Staph aureus also produce an impressive number of toxins and enzymes that help them trigger immune responses and destroy healthy tissue, truly wreaking havoc in the body. When we first started using penicillin to treat Staph aureus infections in 1941, over 90% of staphylococcal isolates were susceptible to the drug. However, resistance to penicillin developed quickly, partially due to the natural evolution of the bacteria, but accelerated by overuse and inappropriate use of these drugs by humans. Many of these bacteria can produce what's called penicillinase, or beta-lactamase, which easily renders the antibiotic ineffective. Even worse, these beta-lactamase enzymes are commonly found on transmissible plasmids, which can be traded between bacteria, essentially like trading cards. The thing is, bacteria are inherently driven to evolve, and as humans, we're pretty good at helping them do that. The incidence of disease caused by MRSA has increased significantly worldwide, and the bacteria continue to evolve and take on new traits. For instance, in 2002, scientists found the first staph strains to be resistant to vancomycin, which is one of the few last resort treatments against MRSA. Vancomycin-resistant staph strains, or VRSA, are rare for the time being, but health officials fear incidence of these strains will rise. To reduce your risk of MRSA infection, CDC recommends always maintaining good hand and body hygiene, keeping wounds clean and covered, avoiding sharing personal items such as towels, and checking in with your doctor if you think you might have an infection. And in general, always make sure to only take antibiotics when you truly need them, and when you do, take them exactly as instructed. With some smarts and some luck, we can get rid of these little guys within the century. Thanks for watching, guys. Subscribe to my channel for more tutorials. Support me on Patreon so I can keep making content. And as always, feel free to email me, ProfessorDaveExplains@gmail.com.
According to a Minnesota Department of Health fact sheet, Methicillin-Resistant Staphylococcus aureus, or MRSA, was first noted in 1961. The first nosocomial outbreak in the United States occurred in 1968 in Boston, Massachusetts. MRSA is a type of staph bacteria that can be found on some people's skin or in their nose. For those who develop an infection, it is resistant to many antibiotics. Traditionally, MRSA infections have been associated with hospitalization or other healthcare-associated risk factors. However, in recent years, healthcare providers have observed MRSA infections in an increasing number of people who lack traditional healthcare-associated risk factors. These people appear to have community-associated infections. The Minnesota Department of Health goes on to report that community-associated MRSA infections are defined as MRSA infections in people with no history of the following risk factors within the year prior to the MRSA culture date. They include no hospitalization or surgery, no permanent indwelling catheters or percutaneous medical devices, no residence in a long-term care facility, no dialysis, and no MRSA culture less than 48 hours after hospital admission. The agency also states that the majority of community-associated MRSA infections present as skin and soft tissue infections, such as abscesses or cellulitis, but they can also cause other skin conditions. In rare cases, community-associated MRSA can cause invasive infections, such as joint infections, necrotizing pneumonia, or septicemia. According to the Centers for Disease Control and Prevention, MRSA is usually spread in the community by contact with infected people or things that are carrying the bacteria. Anyone can get MRSA, and the risk increases with activities or places that involve crowding, skin-to-skin contact, and shared equipment or supplies. Aside from medical patients already receiving care that were the traditional populations considered at risk, athletes, daycare and school students, and military personnel in barracks are considered to be at higher risk of developing this type of infection. These are just a few things to know about community-associated MRSA. To learn more about this or other microbial, infection control, industrial hygiene, environmental health, or safety issues, please visit the website shown on the screen.
Conclusion. It is concluded that there is a significant increase in the number of cases of skin and soft tissue sepsis, both community and hospital in our environment caused by MRSA strains. The most effective treatment includes the use of sulfamethoxylate, trimethoprim, or doxycycline associated with cervical drainage of the lesion. Thanks for watching.